Good afternoon. Welcome to this afternoon symposium, sponsored by Shockwave Johnson & Johnson, entitled Expanding Our Horizons in Coronary Calcified Lesion Management with Intravascular Lithotripsy. My name is Tan Hui Chim, and I'm a spokesperson for this session. And with me as the anchor person is Dr. Benjamin Halton, who just arrived from Paris just a while ago. And with me also in the panelists will be Dr. Annapurna Kala, Dr. Bharat, Dr. Frankie Tam, and of course, Dr. Davinder Chadha. So the session objectives for today is to tackle calcium morphologies with shockwave intravascular lithotripsy, understanding the unique mechanism of this device, to know the latest clinical data and insights, to learn how to manage the complexity of diffuse lesions, and finally to handle the challenge of nodular and eccentric calcium. So with that, I'd like to invite our first speaker and our anchor person, Dr. Benjamin Halton, to take us through the current evidence update of Shockwave, the clinical trials with intravascular lithotripsy. Dr. Halton, please.
It's a real pleasure for me to be there and share with you what could be the latest scientific evidence in IVL. So if we are talking about the landscape of science, we have to identify three different resources. The data coming from large registries, the studies with IVL in comparison to other plaque preparation device, and of course, some kind of specific subset for IVL. So if we dive in all-comers registry, there is more or less 4 big registries, 3 from Europe, the Benelux one, the France Lily, which is the national French registry, and the Replica, which is the Spanish registry. And of course, there is the important Shock India registry led by Ashok. And more or less, this registry have the same design with efficacy defined by procedural success and safety endpoint with procedural complication in hospital MACEs and 12 months follow-up. So if we consider procedural success, the different studies are quite consistent, and we can assume that the overall procedural success, which is defined in all the studies like residual lesion less than 30% within hospital MACE, is achieved in more than 90%. And if you go into the Shock India registry with more 1,000 patients, you can see that the procedural success was higher than 95%. So an important success with IVL in terms of procedural. If we consider procedural complication, and it's now something which is obvious in our daily cath lab, we can assume that IVL is a safe device. And in the French National Registry on 500 patients, you can see that the rate of complication is very low, less than 1% of complication. What can differ between the different registries is more on midterm endpoints. And if we focus on French Lily, which was been published this year in Your Intervention, the 12 months TVF is 90.6%. And it's mainly driven by TVR, you see 5.6, and a low cardiac death, 2.6. But if you focused on the Spanish registry, you can see that there is nearly 16% of MACE at 1 year. And this difference is probably leading by 2 causes. The first one is that registry was ongoing during pandemic of COVID, but also for the composition of the cohort, because, and Professor Chadha will dive into further, it's 60% of acute coronary syndrome. So you can see that there is 5.5% of cardiovascular deaths at 1 month, very different from the 2.8%. And when the others, Dr. Rodriguez, go on the MACE predictor of this study, you can see that acute coronary syndrome has a huge impact because it was the main predictor of TVF at 1 year. When we go back to the French Lily, we have identified 4 predictors of MACE at 1 year. The first is more setting of the disease, peripheral disease, multivessel disease, something very known. But we interestingly shown that the number of pulses delivered to target lesion have a huge impact. And you can see that the curves are very different if you apply 80 pulse or more at the target lesion or less. So this is very something new. So it's full a gap in IVL, which is how many pulses do I have to do on my target lesion? This is one of element of answers. Of course, we have to say humble. This is the only trial who show that, and you need confirmation. But it's a gap. When we focus on IVL comparators, the Bali study was presented at EuroPCR. It's a randomized study, IVL versus conventional balloon preparation, 200 patients. And what we see, and that's IVL do better in the primary endpoint than conventional preparation. However, we have to assume that this study have a kind of weakness. And if you focus on procedural preparation, you can see that there is a high use of rotational arterectomy, which make a confusion on target preparation, but also on the definition of the primary endpoint, which is a combined primary endpoint on procedural success, stent delivery, residual stenosis, and TVF at 1 year, which is a clinical endpoint. So it makes quite confusion. So it generates hypotheses, but we have to keep in mind this limitation. More interesting, and I share with you this very interesting paper led by our American colleagues in JACC Inter this year. They, on the ex vivo, 6 cadaveric patients, they analyzed by OCT, micro-CT, and histology the number of fractures, but also the medial injury led by a randomization by IVL, cutting balloon, or ultra-high blood pressure balloon. And this is very interesting. There is no difference in terms of number of fractures between the 3 groups. However, and you can see it, there is a significant less medial injury with IVL. And it's something very important to take in account, maybe for the outcome of the patients. And another point which is very interesting is that this is quite consistent according to the calcium arc. If you treat concentric arc or eccentric arc, less than 180 degrees, you have the same effect with IVL, but whereas you don't have it with the other comparators. So again, small samples, but it's generating a lot of hypotheses and something that we have to take account. If we compare IVL versus atherectomy, we can share this data coming from the Rolling Stone registry, which is an Italian registry, more than 1,000 patients who compare IVL to atherectomy, rotational or orbital. And in terms of primary effectiveness endpoint, there is no difference. However, you have a signal on less MACE at 30 days in IVL group. Keeping in mind, again, this is not a direct comparison. This is not randomized. This is an observational registry. So we have to be cautious on this result. But again, it's a signal. And to overcome this problem, we lead in France a study which is called ICAR, which has been presented at LBT or PCR this year, which is a head-to-head comparison between IVL and rotational arterectomy in a non-inferiority disease. And the main point, the primary endpoint was MSA. You can see that there is no difference in terms of MSA by OFDI between the rotational arterectomy group than IVL. Interestingly, we have shown that there is much more major malapposition in the rotational arterectomy group, and it's something that we are actually studying on. But again, this is new data. And finally, the last trial comparing in a randomized fashion IVL versus the other one is a roller coaster led by Alfonso Jurado, and he gave 3 arms, rotational arterectomy versus IVL versus LK, on a non-inferiority trial for final stent expansion. Just take your attention on this line, which is the need of a second plaque modification therapy after the first one, nearly in 10% of each case, which means that maybe one device doesn't fit for all situations. And I think it's something very important. And if we compare IVL versus atherectomy, there is no difference in terms of efficacy, but less complication in the arm of IVL. And finally, we will focus on IVL-specific subsets, and you know there is a lot of things to do, again, like gender, like acute coronary syndrome, like left main, nodular calcium, and stent failure. And Professor Shada will dive into ICS and nodular calcium. So I will focus on women. And this year at EuroPCR, they present the Emperor Cat study. It's fully female gender trial, more than 400 female. And you can appreciate that there is a very low rate of complication for our ladies. However, there is a quite high 12% TLF at 30 days, but mainly driven by periprocedural MI. And I remember you that periprocedural MI can be only a biological definition without any event clinical. And finally, the subgroup of left main, when we see the review of the literature on IVL and left main, you can see that there is a very low cohort of patients, 44 at this moment for the maximum cohort, so very small cohorts. But thanks to Shock India registry, and Dr. Gupta presents this data at TCT last year, you can see that in more than 100 left main bifurcation, a very low rate of MACEs at 1 year. So giving the impression that we feel that IVL is very safe and useful even in the left main. And this has been recently confirmed by the subgroup of France Lily, which will be published in the next week in JACC Inter, where there is no difference between the unprotected left main group versus the control group. So gentlemen and gentle-lady, if I may conclude, I think the key words for IVL is certainly safety, is something that we know. IVL is a very, very high device in terms of safety, but it's also versatile, and we can use it in a broad range of situations in our daily cath lab. Something which is important to us is that there is a lot of data independent from the industry which are growing and filling the gaps that we have actually in the science, and this is very important. Of course, we lack in certain subsets of patient robust scientific data, but there is also new technology in the pipeline of Shockwave and GNG, and new technology needs more science. Thank you for your attention.
Thank you, Dr. Horton. At this point in time, I also like to invite the audience to submit any questions that you may have via the mobile apps. So I'd like to invite the panelists for any comments on the presentations by Dr. Benjamin Horton. Ben, can I just ask you again, in the French registry, what percentage of the cases that uses IVL were image guided? Do you mandate imaging for all your patients that use intravascular lithotripsy?
Yeah, absolutely. And it's a French pitfall, actually, because we have an issue of reimbursement of intravascular imaging. So in France, it's only 20% of patients who underwent ICE. It will change in the next months because we have finally a reimbursement of IVUS and OCT. So the data will change, but it's a law. Yeah, absolutely.
Can I? So I think that's a nice question. You know, imaging plays a very important role if you have a calcified coronary artery disease, because you have either 80 or 120 pulses, and you have to be very judicious in using them. So getting to know the severity and distribution of calcium is very important, because OCT is going to tell you the thickness. So you can kind of focus on the areas where you really need to crack. So and all this is not possible angiographically, because the vessel is diffusely diseased. So imaging really helps and adds on. And that one very interesting finding I noted was from the French registry, the number of pulses and the outcomes. So, I mean, if you have the pulses and you are treating a single vessel disease, you might as well use all of the pulses judiciously and complete, because that has got a direct bearing on the result. So that's a very good point, which is out of the French registry.
One of the lessons that I learned from one of the articles that you cited is that sometimes after IVL, you may not actually see obvious crack on the OCT or IVUS, and yet on the micro CT, you can actually see a lot of cracks and so forth. So the IVL is actually still working, and it will actually facilitate the calcium fracture as you post-dilate it with an NC balloon or something like that. But Benjamin, I was going to ask you, we all know that calcified lesions are quite different. Not every calcified lesion is the same. And so, in fact, the treatment of calcified lesions has to be individualized, while IVL is very versatile. It treats all kinds of calcified lesions. But how do you randomize patients in the clinical trial of IVL versus rotational arterectomy, where clearly there are situations that will favor rotational artery. And so I always find that enrollment of patients in such trials is very difficult. What's your thing?
Yeah, absolutely, and it's a pitfall, but in the ICARS trial, the first step was mandatory is to be able to cross a 2 mm balloon, so we assume that the lesion is not uncrossable, which is the field of atherectomy, of course, but you're absolutely right, it's quite difficult to say, and the selection was based on the angio. But you mentioned something very important in terms of calcification. They are not the same. And there is actually something about the density of the calcification, which is coming from the CT scan analysis, and something maybe if you have a concentric calcification art, you can have also a difference in terms of density of calcium. And maybe this is the future to analyze what kind of trial and device I will use according to this new density parameters. So this is very interesting.
You know, we always think that the more pulses you administer, the more cracks you will get, but we have never proven that on any of the images.
Yeah.
Do we have data for that?
No, that's important. I present you the difference in terms of predictor of TVF according to the number of pulses. In the French registry, it was obvious. However, this is the only study who showed that. So we have to be humble and cautious. Okay, there may be a bias. But I present you also the cadaveric study, and we know that Shockwave is again working on, and maybe with a number of pulses increasing according to this new cadaveric study, and maybe it will give insight in micro-CT, in histological, to see if you raise the number of pulses, it gives you difference at the level of histopathological. This is in the pipeline.
One more input I'd like to add. Especially a type of calcium, that is calcific nodules. It's one of the most difficult thing to tackle when we are dealing with the calcific vessels. And I think other than orbital atherectomy, wherein it would shave off the nodule very well, in rotational atherectomy, usually because of the wire bias, we are not able to get good, and the risk of perforation would be more in eccentric calcific nodules or the protruding calcium. But in Shock India registry, there were a lot of patients with calcific nodule who were addressed, and the result was very good. So another tool to use, if you see calcific nodule on imaging, you should use IVL, because that is another thing which will create cracks. At the same time, it will not harm the healthy side of the vessel. So that is one more indication. And also, if you have a very concentric and very deep calcium, in deep and very concentric calcium, usually orbital and, I mean, obviously rotational may not help you because it orbits in the air, sort of. But IVL, if you 1:1, if you take IVL balloon, it definitely creates great cracks in the deeper levels of calcium, and the stent expansion would be better. Stent malapposition won't be there. So these are the, specific indications to use IVL in these subset of patients. That's what I was.
I guess, Benjamin, excellent real-world representation of the use of IVL. I guess in the registry, were there any Achilles heels that came out? So, areas where IVL maybe you thought may not be useful, but ended up being quite useful, like nodules, like diffuse lesions.
Yeah, absolutely. And the weakness of IVL is the number of pulses, is the profile of the balloon, of course. There is what you are talking about the subset studies that we need. We need more data on everything you not embedded in the clinical studies. However, keeping in mind also it's registry, so it's observational, so there is a limited data science on that, but of course we have to work together to increase the number of patients in the subset study where we have some gaps. Again, it's perfect observation, yeah. And I think it's a good spring up for the next speaker, and I will ask Professor Chada to tackle IVL and challenging settings. Thank you so much, Professor Chada.
Thank you. Well, management of calcific coronary artery disease is complex. And the complexity comes not only from the lesions, which you see they are tight, angulated, there are chronic total occlusions, left mains, but the patient subset is also very complex. They are invariably with multiple comorbidities. CKD, COPD is not uncommon, and they are diabetics. And you have challenging settings, and to name one of them is acute coronary syndrome. That's a very challenging setting. So the optimal plaque modification is the only way forward, because if you've not modified the plaque, you're not assured of good stent expansions. And we have this device which acts, not only it is one of the safest device which you have with a very short learning curve, and it assists in the plaque modification, giving you good results. And the evidence of this came from the diffuse AD, and it gives you a luminal gain to the tune of 1.7 millimeters, which is kind of unmatched, and it's considerable. And it does so by modifying both superficial and deep. I must admit here, this is the only device which is acting on the deep calcium. Rest all of the devices for plaque modification act on the superficial calcium. So if you have to look at the indication, the first way is, most important way is to demonstrate calcium, and there are different ways you can do it. You can do it CT, angiographically, or IVUS OCT, score over all these. And the recent revision in the classification of the severity of calcium mandates that these three things to be looked into. And if you have these are the lesion subsets where IVL is going to work. And we discussed this point when Professor Stan asked about randomization. The first question is whether you're able to cross with the balloon or not. If not, then either rotor or laser are going to help you. And once you cross, you deliver the pulses. And thereafter, it is very important that post-IVL you dilate these lesions, because this is the only way you are going to separate the segments of the fractured calcium and restore the compliance of the vessel. So we definitely need IVL in these challenging situations, and I'm going to dive a little deep into ACS and nodular calcium. These are two conditions which offer a little challenge. So let's look at the ACS. Safety and efficacy of IVL came from most of the chronic coronary syndrome patients. But if you see 10% of the acute coronary syndrome patients present with a lot of calcium, IVL appears to be a very good tool in these patients. Why? Because you just have to inflate the balloon, so the chances of vessel injury are a little less aside. That's what we were shown from the French registry. The distal embolization is less. And we know that we can't use thrombectomy devices if you have thrombus in the lesion. And it works circumferentially. There is no wire bias here, so the calcium is going to be fractured circumferentially. And the learning curve is pretty short here. Now, but the problem is there are not too many papers, and this was one of the first papers which came from UK in STEMI patients. And this was 72 patients with 57 de novo and 11 ISR patients. And the results were pretty good. In fact, in the imaging arm, they noticed that most of the patients achieved 104% stent expansion. The MACE rates at the end of 30 days was just about 18%. So it kind of established that doing IVL in the acute setting is feasible and can be done. Well, replica registry, which was discussed, this was the first real-world registry from the Spain, where they did almost all the cases. These were left mains, bifurcations, these were complex patient subsets, and in total about 63% of these patients had acute coronary syndrome, 20% heart failure, and 30% had reduced ejection fractions. And 49% of these patients were undilatable. So it was the registry which looked into very complex lesion subsets, and IVL could be delivered in 99% of cases. So what I'm trying to bring home a point is that this is a therapy which is deliverable. The residual stenosis of more than 20% was seen only in 30% of the patients, and the complication rate was pretty low despite having a high-risk subset of acute coronary syndrome. Now, when you look at the follow-up of these patients, there was positive clinical outcomes were maintained over a period of time. The MACE at the end of 12 months was only about 15.7%. And if you look at the gray and the blue boxes, the important message here is that if you have a underexpanded stent on the table, and if it is treated then and there with the IVL, the results are like that of a de novo lesion. And the red bars are the ones which are because of ISR or the patients who've had stent implanted. So, but if you see what are the main predictors, which Professor Horton already pointed out, it was the ACS and the IVL for the ISR treatment, which were the major predictors of adverse outcome. Well, Benelux was the other registry which looked into complex patient subsets. Now they went a step ahead. They had about patients who were on mechanical circulatory devices, hemodialysis. They also did IVL for vein grafts, and they had a considerable number of acute coronary syndrome patients. And when they compared the results, there was absolutely no difference at 30 days and 12 months in the outcomes of the results. So, I mean, this kind of further established that ACS is one subset where the device works and the outcomes are not very different. Yes, ACS does carry a lot of more, carries poor outcomes compared to the chronic stable angina. Now, this was the National Cath Data Registry of US, where they looked at, for a period of about 2 years, they got about 6,800 ACS patients, of which 91% was non-STEMI. They treated about 7,000 plus lesions and 57% severely calcific. And they looked at the 94% of these patients had less than 30% residual stenosis. And a lot of them required, as was discussed, that no single device is capable of handling any given lesion. So you had a combination of devices where atherectomy was used in about 10%. And yes, of course, stents have to be used post-IVL. And they noticed some adverse effects, which was to the tune of 11.7%. They kind of compared these results with the bedside risk predictor. And when they compared these two, there wasn't much of difference in the outcomes. So the hospital outcomes were very much similar to the predicted outcomes. So IVL had done quite well in this retrospective analysis of the National US Registry data. So the device was safe and effective, and this Rolling Stone registry, which has already been discussed, we know that we do a lot of atherectomy in these patients, and if you do a head-to-head comparison, as was stated by Professor Horton, if you see patients with the ACS do slightly worse than patients with chronic stable angina, but if you compare atherectomy, which is purple, with the orange bars, and the patients with IVL did a little better, and the 30-day and the 1-year outcomes were better with the IVL, and the outcomes for atherectomy were probably poorer because there were some deaths which were reported. There were abrupt vessel closures as well as some groin complications which drove the poor clinical outcomes with atherectomy. Now, if we have to compare both these two devices and the high pressure balloon, there was a nice paper which was shown. I mean, the procedural success rate, of course, with atherectomy and IVL is much better. IVL balloon is little bigger in size. It's a 043 to 047, so crossing the lesion is difficult, so you need to prepare the bed well. The microvascular dysfunction is essentially seen with atherectomy. We know that it kind of shaves and embolizes distally, and the operator curve, learning curve is little more with atherectomy devices. We have some complications with atherectomy which are unique to that setting because it's kind of shaving, and the MACE rates in all the three are kind of comparable. So what I'm trying to bring home is that IVL is one device which is safe and effective, even in subsets with acute coronary syndrome. Let's look at the calcific nodules. Calcific nodules are seen in about 5 to 10% of patients, and these are generally seen where the calcium load in the vessel is on the higher side, and they account for nearly 5% of the coronary thrombosis. If you look at the long and short-term outcomes, they are poorer in terms of number of MACE, the clinically driven target lesion revascularization or stent thrombosis. Everywhere the nodules are going to do worse. And this is a paper which shows you the 5-year outcomes. It's about 3 times higher MACE rates with the calcific nodules. And we have till date been using either orbital or rota for treating these lesions. So the role of IVL is emerging. And if I have to show you the pooled analysis of the disrupt CAD data, they kind of treated about 80% of eruptive nodules and 60% non-eruptive nodules. And what they noticed that the IVL works equally well in both these subsets. And there was no difference in the stent expansion or the complications, as you can see on the right side of your screen. The device in terms of the minimal stent areas, stent expansion, and everything kind of matched in both the subsets. So there was no difference at the end of 2 years also. If you see the stent failure rates in the calcific nodules, it was slightly high numerically, but it didn't reach any statistical significance. So the device is working. I'll show you one case example. This was a calcific nodule in a patient with proximal LAD. It was kind of balloon uncrossable. So we had to use rotablation. So we rotablated this lesion, and post-rotablation, we did imaging. And you can see visibly in the longitudinal axis, you see a nodule which is jutting into the lumen. And this is the nodular segment with a suitable wire bias. So there was a lot of calcium. This is what I was bringing to the notice of the house, that when you have calcific disease, it's there in the entire vessel. So even the left main was calcified. Now, when you deliver pulses, this is how the lesion opens up. So there is, in the first cycle, you see a considerable waste, but as you keep delivering the cycles at that site. Now, the beauty of this device is that it delivers pulses circumferentially. It not only cracks the nodules, but it also cracks the adjacent calcific bed, so which kind of flattens the nodule, and this is what happened in this case. If you see the nodule is completely flattened at the end of the IVL therapy, it's something like this. You shave the nodule off with the rota, and thereafter you deliver the pulses, and once you deliver the pulses with the stent, you're going to kind of compress the nodule and the surrounding area, and what you get is a good result, and there's optimal stent expansion. So the virtues of IVL in a calcific nodular segment is that it modifies not only the nodule but also the surrounding area. It works equally well in eruptive and protrusive nodules. Yes, with the protrusive nodules, the malopposition is a little more, and the kind of fracturing which you get with the eruptive nodules, you don't see with the protrusive nodules. It works independent of the wire bias. It modifies both the superficial deep calcium and it restores the vessel compliance, giving you very good MSAs. To conclude, I would say that intervention in heavily calcific diseases is on the rise, and IVL appears to be one of the most suitable tools in this subset. It provides you a very predictable outcome by circumferentially modifying the calcific plaques. It fractures the plaque irrespective of its thickness, depth, and location. And it aids in optimal stent expansion, which probably is the only thing which translates into good long-term results. Yes, it definitely has a final stay in the treatment of calcific disease, but we do need more than one device for producing optimal results in this milieu. Thank you so much for your patience.
Thank you so much, Professor Chada. I propose that we go next for the cases, and after you will be targeted of question, both of you, because it's so interesting. Subset calcified nodule is a black box of our daily practice. Thank you, Dr. Tam, for sharing with us an iconic IVL cases.
Yes, thanks. So I'm Frankie Tam from Hong Kong. So thanks for the invitation to be here to share a case. So this is my disclosure. So today I would like to share a practical case that with complex patient, complex anatomy, and decision of use of different calcium modification device, MCS, and also bifunction stenting. Right, so this is a 68-year-old man, he's got multiple myeloma. He just has, unfortunately, a newly diagnosed colon cancer. He presented with stable angina and SOP. You can see that the echocardiogram show poor ejection fraction. Actually, the MRI can show that there's LVEF reduction and also induced ischemia and at LAD territory. CTA so calcified LAD, but unable to access the lumen. So after discussion with patient, GI surgeon, and also the anesthetist, we decided to proceed to revascularization before and then resection for the colon cancer. So this is the angiogram of this patient. You can see this diffuse tight stenosis in the LAD from the ostium to the mid and also to the distal LAD. You can also see this the stenosis in the osteodiagonal. You can see this diagonal is major diagonal, single principal diagonal, which we think that this diagonal cannot be lost. So the RCA, luckily, the RCA is not that bad. You can see mild to moderate stenosis in the RCA. All right. So we proceed to the PCL of the LAD. So we use 7-French guiding, workhorse wire, and somehow the IVS catheter cannot pass down to the proximal to the mid LAD. So first is uncrossable LAD stenosis, right? What will you do? You should do the small balloon, or you do just do atherectomy. If you want to do atherectomy, how about this patient has the poor LVEF? Do you need MCS, do you need IBP, or do you need impeller for this patient? Right? So this patient, right, we access the femoral artery as a backup. We didn't put in the impeller or IBP yet. And we try to do water ablation first. So we cannot cross our microcatheter. So we primary water wire, the LAD, and we start the water ablation with a 1.5 burr. 180K RPM. Luckily, several ones, the bird just passed through the LAD lesion. And afterwards, with this angiogram, you can see the LAD is okay, but already see there's some reduced flow to the diagonal, which is not an uncommon complication of the root ablation, the side branch compromise. Okay, at this time, patient is still stable, so we pass the IVUS down to the LAD, and you can see there's a concentric calcified plaque from the proximal mid to the LAD lesions. So, so what's next? So afterwards, we wire the diagonal with small balloon dilatation to a diagonal branch. Still, there's still text inertias in the osteodiagonal that we cannot pass the IVUS catheter down to the D1. So this is the angiogram after the small balloon. Now the flow to the diagonal is better, but now you can see the flow down the LAD is worse. Okay, so what's next? What should we do? So now, of course, we think the LAD is a more important vessel. So we first tackle the LAD, because now we don't want to lose the wire to the diagonal. And this is how a Shockwave can play. So 2 wires, we can maintain the 2 wire access to both vessels, and we pass down the Shockwave C2 plus 3.0 to the LAD. And you can see the Shockwave works quite well. After the first cycle, you can see the balloon expand quite well, and also the mid proximal, the Shockwave balloon works quite well. Totally, we have a 10-second cycle for 12th cycle, so of the C2 plus to the proximal to mid LAD. So this is the angiogram after the Shockwave. So you can see the flow now down the LAD is much, much better. And after that, we perform an IVUS. So you can see this beautiful calcium fracture and cracks from the at the proximal LAD and the mid LAD and here. So you can see very nice fracture and also a very good luminal gain after the Shockwave balloon. So how about the diagonal, right? As I've mentioned, the IVUS catheter cannot cross the diagonal. So what should we do? Actually, we have a IVUS from the LAD, and we can see that the osteodiagonal, again, is very, very calcified, right? You can see a big calcified plaque in the osteodiagonal, which explains why the IVUS catheter cannot pass down to the diagonal. So what will you do? Balloon, atherectomy. If you want to do atherectomy, then you have to remove the LAD wire, right? And now we can see that there's some dissection in the LAD and also the diagonal. Will you dare to remove the LAD wire? If you want to do atherectomy again, will you need MCS, right? And how about the stenting strategy? Do you want to do a complex LAD D1 stenting, or do you want to do a provisional stenting with DCB? And also for the LAD stent, we would like to land the stent at the left main of the LAD. So all these are the common scenario and the common complex decision we have to make during a daily practical PCI. So let me tell you what we did. So we first have a very small balloon to dilate the osteodiagonal. And then here we try to put in our Shockwave 2.5 balloon down to the diagonal. I'm not sure whether you guys have tried this maneuver. So this is so-called the modified Leopold crawl technique. Somewhat like sometimes you do it with our usual semi-compliant balloon and also the scoring balloon. Sometimes we can do this with our Shockwave balloon. So we use our support and then we push the Shockwave balloon down as much as possible, and we inch the Shockwave balloon bit by bit by using the after each cycle of Shockwave delivery. So you can see in this patient, luckily this modified Leopold crawl technique works for this Shockwave balloon. You can see this is the first cycle, second cycle, third cycle, and you can see our Shockwave balloon actually can deliver to the osteo, to the mid-diagonal one, which can deliver the Shockwave, and also you can see the balloon expand quite well. All right, so this is the angiogram after the Shockwave balloon to the diagonal. You can see the flow is quite good. And the good thing about this is that after we perform an angiogram, you can see actually we have some cracks, fracture in the calcified plaque in the ostium diagonal and also the proximal diagonal. And we can see we also have quite good luminal gain here. So this brings us to another, that we don't want to have complex treatment strategy here. So we DCB the diagonal, and then we put in stent in the LAD. So this hybrid approach to this complex calcified lesion, which simplify the treatment strategy here. So this is the final IVUS. We can see very good stent expansion from the mid to the proximal LAD. You can see the diagonal is coming soon, and our diagonal is coming soon, and also our stent just land at the osteo LAD. So these are the final angiogram. Right. So in conclusion, severe clinical calcium is a major PCI challenge, and combination of various devices is essential for complex PCI. And the patient clinical condition is also important when we choose which calcium device we want to use. And again, hybrid use of DCES and DCB may avoid complex handling strategy, which is beneficial in hybrid risk patients. So that's the end of the case. So thank you very much.
Thank you very much, Frankie. Please. Frankie, thanks for your complex case. I'm just thinking when you are dealing with a bifurcation lesion, and especially when you have a C2 plus where you have 120 pulses, sometimes I leave some pulses behind just in case I need to deal with the side branch here. Because to take out two C2 plus balloon for both the main vessel and side branch, because the side branch turned out to be also a 3.0 millimeter, it might be a more cost-effective strategy. What do you think?
Yeah, I kind of agree with that, right? So because before the imaging to the diagonal, we are not 100% sure about the vessel size, right? So we think that maybe a little bit conservative 2.5 is a safe option. And in this case, because the LAD is very, very long, so we want to put all the 120 pulses to the LAD, and so we open to Shockwave in this case. But I agree that if we know that, I mean, the diagonal is such that big, probably the C1, 3.0, C2 plus do all the lesion here.
Yes, because sometimes even if you oversize a little bit, because it's 4 hemispheres that we are inflating, you're not likely to cause any damage. The other point I have here is your leopard claw technique. Do you think it works for a large profile IVL like a 3.5, 4.0 as well? Because the profile is quite big, it's hard to push forward.
Yeah, that's true. I won't say that leopard claw will work for every uncrossable lesion. So I think it depends, right? So for example, if a really tortuous, tight lesion, a big IVL balloon may not work in this case. So I think case by case.
I was going to ask all the panelists here. So, after all, IVL is a adjunctive device for modifying a calcified lesion. Is it fair to attribute the MACE and the final outcomes to this particular device when there are so many other factors involved here, from the patient's factor to the stent factors and postural factors? So how do you attribute an outcome to an adjunctive device like an IVL or even rotational arthrectomy?
It's for me. It's a complex question. Yeah, you're right. It's a limitation, and we've seen it in the Bali trial, where we cannot assume that the effect is only related to IVL or atherectomy. Does it matter? I think the most important is the results that you need for your patients. And so far, maybe adjunctive therapy for the best results is necessary and not to opposite, the tools between them when it's necessary. Keeping in mind that we are searching and you are a lot of important user of intracoronary imaging, which is necessary for the outcome now, we know it. And I think whatever the effect of the preparation tool, the goal is the results. But I also have questions for you and everybody. Maybe we have questions in the floor because we have seen
no questions.
Wonderful, no questions. Professor Shada, we've seen wonderful cases. You see a flattened nodule after IVL. Can you give us just insight on your experience? How you know in nodular calcified lesion that you have enough prepare your lesion before stenting? Because I think it's the main pitfall.
So I think we know that there are two major type of nodules which we encounter in the coronary tree. One is an eruptive nodule. This is made up of plates of calcium with thrombotic material. These are compressible nodules, easily modifiable nodules. And the other subset is protrusive. That means this nodule is protruding from the media and the overlying surface is smooth. What we must remember, wherever there is nodular calcium, there is a lot of the calcium load in the vessel is on the higher side. These nodules are generally in the proximal part of the vessel because the plaque volume is higher in these segments. So you would get to see them in proximal circumflex RCA. They are around the bends. And if you deliver therapy and if you do dilatation, if you get good luminal gain, that means the nodule has been compressed. So these are called compressible nodules. Whereas the other subset is which do not give way. These are protrusive nodules which have smooth surface, which will in addition need some ablative therapy. But here again, IVL works because it works on the surrounding tissue. It creates certain cracks on the nodule itself, but the results are not as good as the eruptive nodules. So it will kind of compress and make you, if you're using imaging, you will see it. Even angiographically, you will be able to see post-dilatation that the nodule is now compressed and gone into the vessel wall. So what is important here is if you can differentiate on imaging. If not, you deliver the IVL therapies distal to proximal, because histologically they've shown that the collagen-rich calcium is there. As you were telling, very soon we'll have characterization of the type of calcium which is in the vessel. So collagen-rich calcium is a tougher calcium, and that is what leads to the, it is there in the proximal and distal segment, which leads to nodules being present. So, angiographically, if you've done the IVL, post-IVL ballooning, you will be able to see the results.
I think the question has always been how much is enough in terms of delivering the pulses. So we oftentimes go in with this buffet syndrome, I'm going to eat as much as I can. So I have got 120, I'm just going to use it all at one goes. But I think most of us do agree that if you use an orthogonal view where you don't see any wasting of the balloon after 30, 40 pulses, you probably have done enough in terms of lesion preparation.
Thank you so much. It's a pity because we have to close the session. It's only 45 minutes, and I asked Shockwave for next year to make a longer session because we can spend one day on nodular calcification. So thank you so much. I learned a lot today, and I think that future is now. We have seen that how IVL can be useful in our daily practice, safe, and so versatile, using in a lot of situations. And thank you so much to all the panel, great panel, and thank you so much to assist this session, and enjoy the rest of your meeting. Thanks.
Thank you.